Thank you for joining us today. And we are very honored to have Dr. Lusine Poghosyan as our keynote speaker for our annual Bullough lecture. So Dr. Poghosyan is the Stone Foundation and Alice D. Fish Professor of Nursing and Professor of Health Policy and Management at Columbia University. She is a distinguished health services researcher renowned for her contributions to the study of primary care organizations, healthcare workforce dynamics, teamwork, and the quality of patient care, with a particular focus on chronic diseases. With a career dedicated to advancing healthcare equity, Dr. Poghosyan's research yields crucial insights into maximizing the effectiveness of nurse practitioners as primary care providers and establishing robust primary care teams to ensure equitable access to timely, safe, and high-quality health care, especially for marginalized communities and underserved populations. Leading several research projects funded by federal agencies and foundations, including the National Institute of Nursing Research, the National Institute on Minority Health and Health Disparities, the Agency for Healthcare Research and Quality, and the National Institute on Aging. Dr. Poghosyan's influence extends across healthcare spectrum. She is also the executive director of the Center for Healthcare Delivery Research and Innovation, a pioneering institution driving cutting-edge healthcare systems and health services research. Dr. Poghosyan has served in several leading nursing and healthcare organizations, including past service as the chair of the American Academy of Nursing's primary care panel, and then as an advisor on Academy Health Interdisciplinary Research Group on nursing issues. Currently, she serves on Academy Health Board of Directors. Dr. Poghosyan is also a fellow of both American Academy of Nursing and the New York Academy of Medicine. So please join me in welcoming Dr. Lusine Poghosyan.
Well, first of all, congratulations to everyone who got awards. I started taking pictures of the titles and I realized I'm taking too many pictures. So congratulations. What an amazing breadth of topics and expertise. I had a chance to walk around and bump on a few of you, apologizing because there's so many people. It was so inspiring for me to be there and to see. So congratulations. You guys will have an amazing career ahead of you. So because I was remembering my PhD days, I wasn't that smart. So it was extremely impressive. So congratulations for that. And I want to thank Dr. Chang and the Office of Nursing Research for inviting me here. They made it so easy for me to be here because I really, really wanted to be here and working with me. And I'm thrilled to have a chance to speak with you a little bit more about the work we do in my team and leave some time for questions and answers. I'm going to put my phone here to track myself. I like talking. I'm sure you figured that out. But I promise you to stop on time and leave some time for questions and answers. I'm Lusine Poghosyan. That's my Armenian first and last name. As I'm a professor at Columbia, I've been there for about 13 years. The plan was 3 years, go to New York City, have fun, then leave. 13 years later, I'm still there and I'm still having fun. So we'll see when that ends. So I'm very fortunate. So next 45 minutes or so, I will talk to you about building a program of research. How did I build my program of research? And I hope there will be some lessons helpful for PhD students, for graduates, for DMP students, for everyone to see how I managed to build a program of research for myself. I will also provide some examples of the studies that we have done, so you will see how studies build on each other and help to grow our program of research. One thing people who work with me know that I'm extremely passionate, it's the most important part of my job, is to train the next generation of scientists who are going to do a better job than I've done and grow nursing science. So I'll talk to you about some of the training opportunities that we have at Columbia and also share my secret that I've been telling everyone. I'm here to recruit PhD students, postdocs. So I never learned that secret you don't say loudly. So please keep an eye. If anything interesting comes up, find me, email me. I put my email in a big letters than my title. So there is a reason for that. And I will conclude about some future plans that my team and I are working in our area of work. So I am a health services researcher. I have a nursing and public health training. Most of my work is focused on anything you see in this area. So some of you might know this is similar to a social ecological model where the main goal of my team and my centers is to conduct research that's going to help to maintain a functional nursing workforce in highly performing healthcare organizations. We believe that is going to help to increase the demand for healthcare services and to assure consistent health outcomes for all. So at the center of our work are the patients. So we do studies that are focused on patient outcomes, range of outcomes. We mostly look at acute care utilization among older adults and try to prevent some of the unnecessary ED use and hospitalization. We also know that patients are taken care of by clinicians and teams. We want to make sure that their well-being is promoted, that clinicians, mostly nurses, are able to deliver high quality care to their patients. So we have a lot of studies focused on job satisfaction, turnover, burnout, trying to understand some of the workforce dynamics. These clinicians work within organizations. So we also look at the organizations. I'm going to give you some examples of the studies that how can we create a better work environment that's going to enable this clinician to deliver good care to patients so we can have better outcomes. But organizations are also within the communities, within a larger environment. We cannot look at healthcare in isolation anymore. So some of our studies, and I'll give you examples, are looking at the policies, particularly nurse practitioner, scope of practice policies, looking at the social determinants of health, larger community factors that affect, at the end of the day, patient care, outcomes, and lead to health disparities. So I gave you a lot, so this is what we do. So I'm going to try to narrow it down and walk you through some of the specific examples of what we exactly do. Most of my area of work is a primary care nurse practitioner workforce. I am not a nurse practitioner. I am a trained healthcare services researcher, although I'll be honored. I'm honored to receive this award from AAMP in June. I am their honorary MP fellow. So I'm super excited about it. So it was, because I've done, thank you. I've done such a, this is a workforce that I think is a key for helping our country to deliver high quality primary care. So the first paper I wrote in this area, my dissertation was focused on nursing workforce in hospitals. I was mostly looking at RNs in hospitals, but more I was doing research, more I was learning. And I've always been passionate about primary care because I believe that's where we can get most out of our investments. We can prevent disease, we can improve quality of life, we can keep people out of hospitals. And so one of my early papers, more than 12 years ago, 10 years, almost 15 years ago, when I started writing that idea, was what I was noticing was that MP numbers were growing. And nobody was really paying attention that what does this really mean for the healthcare delivery? So I wrote this paper making an argument that the growing workforce of nurse practitioners represent a substantial supply of primary care providers, and we have to watch it to see what's happening to this workforce. And we know that their numbers grew, doubled significantly. Now AAMP estimate that there are 385,000 MPs in the country. And this number is going to grow by 45,000 very, very soon. And some estimates show, but by next year, almost 1/3 to 27% of all primary care providers in the United States are going to be nurse practitioners. So we know that physicians, physician assistants are also primary care providers, but MPs are the fastest growing workforce of primary care providers in the country. This is great. Some of us would say, oh, that's fantastic. The numbers are growing. We finally are going to fix the primary care issue in the country. Yes, if we know how to effectively utilize nurse practitioners. So this is where our research comes, that despite the growth of the MP workforce, despite the key role MPs play in the country, there are many policy and organizational barriers that affect the optimal utilization of nurse practitioners and how they're able to deliver care to patients. So, and I'm going to walk you through some studies that have tried to produce evidence over the years to advocate for removal of some of the scope of practice barrier issues, some policy issues, remove some of the organizational issues, so this growing workforce of important clinicians can deliver high quality care to patients. So how many of you are MPs here? Okay, very cool, excellent. So this map might be familiar to all of you, most of you. So this is the scope of practice regulations across the United States. So, you know, while MPs train pretty uniformly across the country, the scope of practice regulation, what MPs can or cannot do, is determined by each state. And there's a wide variation across the states. So in green states here on this map are the states where nurse practitioners graduate, are able to deliver care according to their licensure and training without any restrictions. Yellow states say, okay, you still can do the same thing, but you need to have a physician collaboration. So if it's, you know, whatever, however they define. Red states say, no, you need to have supervised by physicians to be able to deliver care. So again, one of my early studies, I was trying to show that this does not make sense. This is not good for the patients. This is not good for MPs. This is not good for the overall healthcare system. Because imagine it affects the mobility of the MP workforce, patients' access to care. So I wrote that paper, and then it was trying again to call attention on removing restrictions on MP practice at the state level. Then I did a study, you know, with policymakers, you try to argue that, is it going to save money? You know, that's, so we did this study using Medicaid claims data from 1999 to 2011. The reason we stuck with this time frame, because after 2011, Medicaid data is not available nationally. It's a state specific. So we looked all the states in this time frame that changed their scope of practice regulations. They went from restricted to reduced. They went from reduced to full scope of practice. And what we found that in the states that have full scope of practice, outpatient costs were 17% lower. So the summary of this, and there were also reductions in the prescription costs if the states had full scope of practice for MPs. So basically what we showed in this study was that giving MPs full scope of practice could potentially save costs, save money. So we published this paper trying to make a big, communicate that full scope of practice is critically important. So these are just a quick 2 studies to give you an example of how we focus on a state level scope of practice regulation. We show how it impacts cost. Later on, I can show you how we did other studies evaluating these policies. But in the first circle graph that I showed you, I also made an argument that we also need to look at organizations. Fine, you know, working with a scope of policymakers takes time. It's not easy. Changing policies is not easy. Can we change organizations at least? Can we work with the organizational leaders to make the places good for MPs to work? Because when I was starting my career, I was interviewing many primary care nurse practitioners, and they were telling me, I'm the first MP ever being hired in my clinic. They hire me, they want to have an MP, they just don't know what to do with me. Because organizations were not familiar with MP roles, competencies, skills, so they would hire them, but they don't know what to do with them. So I went and I was trying to understand, what does this really mean? Is this really accurate? Like, people don't hire these very well-trained clinicians and don't know what to do with them. So given that I've been trained in large surveys, large database in my PhD program, I wanted to survey a large group of MPs and say, is this really true? Like, how is your organization using you? And when I looked at the literature, there are no instruments. Like, there is no instrument I could send MPs to collect information about their organization. So I wrote a grant proposal, RO3. This is my first federal funding of my career. I wrote this RO3 to AHRQ to propose to develop this new tool. It's called Nurse Practitioner Organizational Climate Questionnaire. I got the money, and I developed the tool with my team. It's published in a nursing research. So the paper is in a nursing research. Later on, we published. So I developed this tool only for my own research program to understand how organizations use nurse practitioners. But now the tool is being used across the country and internationally, and people are using it And they're adapting it for nurse midwife, nurse CRNAs, for nurses working in nursing homes. So this tool, MPPCOCQ, is reliable and valid to capture the work environment or practice environment or organizational climate. We use different terms sometimes, of MPs within their organization. So there are 4 things this instrument measures: MP-physician relations, MP-administration relations, independent practice and support, and professional visibility, which the term emerged from talking to MPs, that telling us that my organization doesn't know about my role, my role is not visible, my competencies are not well understood. So 29 items, 4 subscales, measure work environment of MPs within the organization. So if I want to go assess work environment or assess organization, I need to have a reliable and valid tool. So we developed it. We published 5-6 papers to prove its psychometric validity and reliability and predictive validity to make sure that the instrument measures what it's supposed to measure. So using that instrument, we surveyed MPs in 6 states with different scope of practice regulations. So we made an argument in this paper that came out about 2 years ago in Research in Nursing and Health in 2022. We said we wanted to show if the state level policy affects the work environment of nurse practitioners. And what we found that it actually did. If the state creates a good work environment for nurse practitioners, then it's easier for organizations to create a good work environment for nurse practitioners. So you see how we're starting from policy, we're going to organizational level issues. The details of this paper is published. So one thing you're going to learn in my talk, that I'm not going to give you a lot of methods, so feel free to ask questions at the end. I'll be happy to answer. Okay, now we showed that policies affect the organizations, but then we wanted to say, does organizations affect people? That they affect nurse practitioners. So we published a couple of papers to show that work environment or practice environment is critically important for nurse practitioners. So if MPs work in a good practice environment, they are less likely to leave their job, they're more likely to be satisfied, and they're less likely to report burnout. So these are just 2 examples of the papers we published to show that a work environment is critically important to recruit and retain nurse practitioners, because it's really not good for a primary care practice to hire an MP and lose them in 1 year, in 2 years. So we know that hiring and replacing one person costs the annual salary of that person. So let's say if I live at Columbia, it's going to cost Columbia my salary to replace me. The same thing in hospitals for nurses, for nurse practitioners. So, okay, now we have evidence that says work environment is good for nurse practitioners. Then we went to ask, is work environment good for patients? Can we show that it's important for practices to create a good environment for MPs because that benefits patients? So we did this study in Massachusetts. We surveyed MPs in Massachusetts, and we obtained claims, HEDIS measures from the practices that employed nurse practitioners. And what we showed was that if nurse practitioners work in practices with a good environment, patients are more likely to receive guideline concordant care. So they're more likely to be screened for diabetes. They're more likely to have better HEDIS measures for cardiovascular diseases. So we're building on our work step by step to show that, okay, work environment is good for nurse practitioners, work environment is good for patients as well. But my main goal when I was launching this program of research was, that MP's role was designed in 60s to address health disparities. Because there's, health disparities is one of the persistent issues facing the United States. And that's how MP role was initiated. So with a colleague of mine, she was my PhD classmate, Margot Carton-Brooks, she's at Penn now. We developed this framework where we made arguments that these are the factors that are gonna affect nurse practitioner workforce supply, potentially primary care capacity, and leads to health disparities. So if we really want to address health disparities, then we really need to focus eliminating barriers at each of these boxes. So one example, before I go and exactly show one study that I'm going to walk you through how we tested this model. I want to briefly say, so we tested this model in multiple studies. So this model has been published. It's in Policy, Politics, and Nursing. And I used this in my first R01. And I think right now we've used this model in a couple of R01s to really focus on different aspects of this conceptual framework. So we got R01 from NIMHD. The goal of R01 was to understand ways to reduce racial and ethnic disparities in outcomes of chronically ill older adults receiving care from primary care practices employing MPs. So at this point, my team and I have done enough work. We have enough instruments to be ready to go ahead and make these larger arguments in an R01 study. So NIMHD funded our R01, and we collected survey data in 6 states. I'll show you the states with each scope of practice later. In total, we had surveys back from about 1,200 nurse practitioners who worked about 1,000 primary care practices. I think it's 979 or something. And then we went to Medicare CMS and purchased Medicare claims data of patients who worked in the same practices that we've surveyed MPs for us to allow to merge the survey data. So we basically had clinic from which MPs told us how is their work environment, and we also had their patient data. So it would allow us a lot of analytical testing, a lot of research questions like this one. Using that data, we are able, and this paper is published in Medical Care, we're able to show that if MPs work in a good primary care practice, with a good environments, patients from these practices are less likely to go to EDs and hospitals for unnecessary reasons. So good primary care is able to prevent ED use and hospitalization among older adults. And we made arguments that it helps MPs to deliver better care. It helps MPs to, if the environment is better care, prevention, offer preventive services. This way, patients don't have to go to EDs for exacerbations of diabetes or asthma. So, but as I said, I mentioned is that we also want to show that now we have evidence that good work environment affects patient outcomes at a much larger scale. So this paper is under review right now. So I wanted to share with you it a little bit in more detail. Then my team and I asked the question, is the work environment has the same impact for everybody? So as a patient, all patients benefit from this work environment, or certain patients are more likely to get a better care if the environment is better. And we picked asthma for this one because, you know, what we're learning is that MPs are very much involved in asthma care delivery in primary care practices. And asthma is prevalent among older adults. So we know about 4 million Americans age 65 and older have asthma, and also we know that asthma is challenging to diagnose, treat, and manage. And some of the clinicians, you know that better than I do because of the aging and because of all other conditions like COPD that could look like an asthma. But one of the issues, asthma patients use emergency departments a lot. Primary care can manage asthma and can prevent these ED visits, but we need to understand how to enhance primary care so patients with asthma are not going to EDs for complication. And research is very clear that racial and ethnic disparities exist in asthma. Black and Hispanic patients are 2 times more likely than white adults to go to ED. So we wanted to test new hypothesis to see if we create good environment for MPs to manage asthma in primary care practices, we'll be able to reduce health disparities in asthma ED use. So racial and ethnic disparities in asthma ED use, because evidence is clear that if MPs work in unfavorable work environments, which are they don't have support for the care they deliver, they have a bad relationship with leadership, they don't have access to clinic resources, then in these environments, it's really hard to manage care. It's really hard to deliver care. So the purpose of this paper is study whether racial and ethnic disparities in ED visits among older adults with asthma are moderated by MP work environments in primary care practices. if MP work environment can reduce the disparity in ED visits among Black and white patients. So we used the cross-sectional survey design. We collected data from MPs that I mentioned to you. 1,244 MPs practicing in 917 primary care practices, from which we had patient data from about 46,000 older adults, 65 and older. They had asthma diagnosis. These are the states. As you can see, purposefully, we have picked 2 states that were in a full scope of practice at the time of data collection, which was Arizona and Washington, reduced practice, which was New Jersey and Pennsylvania, and restricted practice, which were California and Texas. MPs completed this instrument that I've already showed you. And we also obtained Medicare claims data for the patients who received care in the practices that MPs completed surveys from. These are our variables and outcomes. So for this model building, we used race. Categories of a race were from the U.S. Census Bureau. We used the MP work environment measure, which was the global score on the MP PCOCQ. And we use all-cause ED visits. And we also use ambulatory care sensitive ED visits. So these are the ED visits that are considered preventable. So we use the logistic regression models to test the relationship between exponential and outcome variables, but we also create an interaction term between work environment and race and ethnicity to see if outcomes change by different work environment scores. So this is our table, some descriptives about patients, where you can see Black patients, almost 48% of the Black patients with asthma had at least 1 ED visit a year, compared to 33.9% of our white patients. And similarly, here you can see that ambulatory care sensitive ED visits, preventable ED visits, were higher among Black patients than among white patients. So from descriptively, we see that there is a different pattern in the ED use among older adults with asthma. These are the description of the practices. So as I said, we have about 917 practices. On average, this practice saw about 667 Medicare beneficiaries, 65 and older. MP number was about 2.8 per practice. What we are noticing that now that their MP workforce is growing, practices are hiring more and more MPs. This number could be much higher now. So, and practices were distributed all over the states. I want to pay attention on this slide. This is our adjusted model. We controlled for everything we could that clinically and conceptually we could, and empirically we could justify. So on the left side is the standardized work environment score. So -2 is the worst work environment score. 1.6 is the highest work environment score we could get, the best care environment. So then I want to bring your attention to the odds ratios. As you can see, odds ratios change for Black and white patients as the work environment goes from worse to good. So at the worst, and so both odds ratios for all-cause ED visits is changing, and ambulatory care ED visits is changing. Here's the summary of the results to make it much simpler, because interaction terms are usually hard to interpret. So MP work environment, what we found was MP work environments moderate the relationship between race and ethnicity and ED use. When patients receive care in practices that have a poor work environment, Black older adults are even more likely to have higher rates of ED visits compared to white patients. So in a bad practice, Black patients suffer more. So which shows that in a good environment, in a good practice, the disparity gets slower. There's still a disparity. There's still white patients are less likely to go EDs than Black patients, but in a good environment, that disparity is narrower than in a bad environment. So we made an argument in this paper that we have to focus on improving working conditions for MPs if we really want to reduce the disparity between Black and white patients with asthma going to EDs. Feel free to ask questions afterwards. I'm going to show another, the paper is under review, so I don't know what's going to happen. So if any of you get the reviews, please be kind, give us good reviews. so it can get published and my team will be nice to me. So that's that, but I wanted to walk you through at least the methods of one paper. So you'll see what we do. We also published recently, like I think it was last year or last year in December. We also showed, as I told you, clinician well-being is very important for our team's work. We show that NPs are experiencing high levels of burnout, and in the burnout practices, patients are going to EDs more often. If the clinician is burned out, their patients are more likely to go to EDs than if the clinicians are not burned out. So these are just some examples of the projects I've led. I have the most fantastic trainees in the entire universe. So they take this data and develop into more projects. My PhD student, Annie on this one, Amelia was my postdoc. So they took the data and looked at the high-need, high-cost patients. Another student of mine, Mint, she's the first author, she looked at the workforce outcomes only on community health centers. So she took a subset of data only for NPs who are in the community health centers. And Eleanor, she looked how NP work environment and emergency department utilization among older adults with substance use disorders in rural areas. So she took our 3 million patient sample on only subsample patients who are in the rural areas, who have a substance use diagnosis, and were living in rural areas. So the trainees are doing a fantastic job of growing this program of research into many different ways. So one of the things I also showed you that we cannot look at the healthcare in isolation anymore. It's the patients, are embedded within the clinicians embedded in teams within organizations, and organizations within communities. And we have an NI in our R01 where we made an argument about how to use practices that use nurse practitioners, hire and employ nurse practitioners to address social determinants of health. So this study is ongoing. It was just funded last year. Our goal is to see if certain NP practices are better at reducing health disparities and addressing, education, built environment, healthcare access. So study is ongoing. I'm excited about this one because it's going to be a national study. This is our sampling strategy. So we're going to recruit about 2,400 practices that employ NPs from across the country, but with specific neighborhoods. We have definitions of predominantly white neighborhoods, predominantly minority neighborhoods, and we also have a definition of integrated neighborhoods. So we are going to launch the survey in September. So waiting for the summer vacations and things, and we're going to be in the field in fall. So if you get surveys and you're an MP, please complete. It's really, really hard to get good response rate and good data. While I was doing this work, what I was learning that from the evidence and from our work, that nurse practitioners are the best providers to deliver care to chronically ill older adults. And there is something magical about NPs in this population. And then I was learning that dementia is a chronic condition. So in my team, we wrote this paper that said, we have, growing NP workforce can be a solution for aging population with dementia. When older adults or others diagnosed with dementia, they really need to good care management of their condition. So we published this paper, and editorial was written on our paper agreeing with us. So that, yes, NP nurse practitioners and dementia care is a perfect fit. So we took this work and wrote an R01 for NIA. So we wrote an R01 where we said, can we better understand how to use nurse practitioners to deliver better care to dementia patients, because their numbers are growing. Almost 7 million Americans now are living with Alzheimer's disease and dementia, and NP workforce is growing. So our hypothesis here, I want to only show you our model. What we are learning from the evidence is that older adults with dementia go to EDs and hospitals many times. And they also see many, many providers in years. So we're looking at the evidence. A person with dementia can see up to 16, 17 clinicians in 1 year. Imagine someone with a cognitive difficulty seeing 17 different providers in 1 year. So we made an argument that NPs can deliver continuous care to these patients. It's going to lead to better outcomes. I mean, our healthcare is fragmented already. Communication is an issue. adding, cognitive challenges, it makes it extremely difficult. So this is the model we're testing to see if MP can continuously see the dementia patients. Can we prevent these ED visits? Can we prevent fragmentation of this, or someone seeing 17 providers in 1 year? So the study is ongoing. We just completed a survey of MPs, and we just purchased the Medicare claims data from CMS. If you guys are, any of you use the Medicare data, you know that new rules, CMS is changing new rules and creating issues, but we got the data, so we're in the process of analyzing and writing papers. So if you invite me back in a few years, I can tell you what we did. So my team and I are growing this work into different areas because MPs are everywhere. So we have an R21 from NIA that says MP delivered home-based primary care, looking at MP delivered home-based primary care. Nurse practitioners are #1 providers home-based primary care. And we see that primary care delivery is moving into community. So MPs are sort of looking to see how to help and support MPs when they're delivering care to patients. We have another RO, we do a lot of work in social network analysis. That's why I took a picture of some of social network analysis abstract that I also saw in the hallway. We have another RO1 study right now from AHRQ where we are interviewing everyone and surveying everyone in a primary care clinic, like 23 of them, and understanding the best team structures. So we do a lot of social network analysis. So these projects are ongoing. I want to make sure I leave time for questions. But another colleague of mine is looking, I'm working with a colleague of mine on another RO1. We're looking at MP workforce in nursing homes because, MPs are also growing in nursing homes. So we're expanding our work in different areas. In the beginning of my talk, I said I really, really care about training the next generation of scientists. Because, when people always ask me what motivates me, why do you want to do all these things? And I was like, and I go to my work in my office and I look at my team, like, these are the people that motivate me. So that's what I'm excited about. Really using the resources, opportunities that I had, my team had to really help and train the next generation to do a cutting edge research. I really think it's critically important if we want to change nursing, if we want to change the healthcare, really have to have a robust evidence. So I'm a PI of a T32 funding at Columbia University. So our goal is to train PhD students and postdocs. So we have spots for PhD students. We have spots for postdoc. If any of these seem remotely interested to you, please shoot me an email. I think we work hard in my team. I think that's what we are known, but we also have fun. I was asked, how can you do all these things? And first thing that crossed my mind is my people, my team. I work with some of the best people in the world who are my friends, who are my colleagues. I don't have to pretend I'm smarter when I'm around them. It's this good place that motivates me, and helps me to do all this work. So these are some of the topics of my trainees' work. As I said, when trainees come and start working with me, I do my work. I already know what I'm doing. I want to help my trainees to carve their own path. But within an umbrella that I know and I understand and I can be helpful, and I have a network to expand. So some of my students, I showed you work on substance use disorder in rural areas. My student defended her PhD on Wednesday on multiple chronic conditions. I have PhD students who are looking at a serious mental illness, limited English proficiency, and care for persons with dementia. So that's what we do. I hope this is what you were expecting. And but one of the things, one more slide before I would summarize. But when we take trainees, we don't leave them alone. Like, okay, what are you going to do after? So I wrote a proposal to AHRQ, R13, to bring the team together, experts of the country, and say, okay, we've been doing so much work on MPs. What else? What else we should be looking in the next 5 years, in the next 10 years? And we actually published the paper in Nursing Outlook. So we came together for Day in Health conference at Columbia. This is Columbia in a 7th floor our building where my conference yesterday was also happening. So we came together, experts from all over the country and internationally, and we sat down and said, what is next? How we can move this body of science forward. So here are some of the questions that came up that We need to understand what are the NP uniqueness of NP care models and how these models impact patient outcomes. We need to understand how to better integrate NPs in practices. We need to diversify the NP workforce. One of the issues of nursing workforce is that it does not look the population we serve. So I think we have to figure out more creative strategies of increasing, diversity of the NP workforce. And one of the biggest challenges that any researcher faces, including us, how to translate our findings into an impactful, meaningful change, working with policymakers, working with administrators. So that's what we do. We have some plans to continue to grow this work as our team is growing. But I hope in this 40 minutes or so, I was able to convince you that research is needed to continue addressing of removal of policy and organizational barriers to maximize contributions of the NP workforce and health quality. We've done a lot. There's a lot of work that needs to be done to really have the robust evidence out. We still believe that NP workforce is key for meeting the care demand. The workforce is growing. The quality of care that they deliver is superb. So we have to just learn how to remove barriers that affect their optimal utilization. NP workforce is critically important for achieving health equity. We know that NP role was designed to address health disparities, and still evidence shows that NPs are more likely to work in underserved areas, to take care of patients from racial ethnic groups, and they're more likely to take Medicaid. So we need, NPs are going to help us to achieve health equity, but we still need evidence to advocate for removal of barriers that this workforce is facing. And next generation is the key. We have to, in nursing, I fundamentally believe, we have to better for the next generation. So I tell my students that when they ask me, what do you expect from me when they join my team? I said, I expect that you have a better career than I have. That's it. That's easy. So I think, but my job as a mentor is lay that foundation so they can have a better career than I have. And that's what I try to do. And I think that's a key and extremely important for our growth and success. I don't do this work alone. I stand here by myself to talk, but I have been lucky to work with some of the most fantastic people in my career who've been with me for years, supported all the crazy ideas I had, brainstormed with me. So it's a very, very, very long list of people. And I also get the best PhD students and postdocs that I learned so much. I had opportunities not to work in academia, but I realized that academia is the only place I can continuously learn. And I learn it from my mentees. So I can't imagine myself doing anything else. And I've also been very lucky. My PhD advisor was Linda Aiken. I'm sure many of you know her. She just took a chance on me, recruited me from Armenia, brought to Penn, trained, and till today we are great colleagues and friends. And she's my, I'm appreciative of her. And these are some of the organizations that trusted our work. So, and thank you all for coming. Thank you for inviting me again. Thank you for spending this hour with me and giving me a chance to share some of the work. I hope I did not confuse you. That's my goal. Thank you. I'll be happy to answer any questions you may have. I'm super proud of being from Armenia. I love, it's part of my identity. It's always going to be part of my identity. I'm actually expanding research in Armenia right now. I submit a proposal to Columbia University, competing with all professors on Armenia projects. So we'll see. I think they were interested because they were asking for additional information. So, it's part of my identity. It's part of who I am. And that I pretty much in every talk as is here, I said, this is my Armenian first and last name. So, and I'm glad nobody said, oh, Kardashians. So yes, so you're absolutely right. But, yes.
I have a question.
Please.
You mentioned impactful outcome to influence change, and looking at the map of restrictive practice, what type of outcome would be meaningful to adjust their perspective of how NP should be utilized to improve outcomes?
No, that's a great question, because what are the outcomes and what are the sensitive? The question sometimes depends who we want to show the impact. Earlier, I said that with policymakers and in lobbying efforts, very often they want to see a cost. So cost measures can be a good outcome to show that, look, if you better use MPs, you can reduce costs. I'll give you one example of a cost study I didn't speak about. So when I was doing this research, I learned that MPs are telling me that, there's whole literature that says, oh, MPs are not as effective as physicians. They don't see the same number of patients. I'm like, okay, fine. Let's understand why. Why MPs don't see the same number of patients. So I did some study trying to understand. Learn two things. One, when patient comes to see a physician, they go first through an LPN or MA or someone who does the height, weight, blood pressure. They go to the MD. When a patient comes to an MP, they directly go to MP. So the MP does all of these things that for MD, someone else does it. That takes time. So then you cannot see the same number of patients as an MD if nobody is helping you. Or you're trained at an advanced skill, but you're doing an MA tasks or LPN tasks where you are advancedly trained clinician. So that's one thing I learned. The second thing I learned is that when physicians have 2 exam rooms, MPs have 1 exam room. So a physician goes from this exam room to other exam room, this exam room. While MP comes out, she or he has to wait the room to be clean to set up for the next patient. So this takes time. So with one of my colleagues, he's an operational researcher. He looks at the queues of a Trader Joe's and the Whole Foods, the lines. So I said, can we use those methods to see, is it costing clinic money? Because if you hire a nurse practitioner, but use them as an MA, you're losing money because nurse practitioner is still making the salary of a nurse practitioner. And then you're reducing your number of patients. So we published a paper that we actually show that if you hire 1 MA to support 2 MPs, you can save money. So we try to publicize those type of work. So I think cost is important. I think quality of care measures are important. That's why we did some of the HEDIS measures. I think these outcome measures are important because nobody likes to go to hospital. Nobody wants to stay in a hospital, and it's super costly. So if we can figure out ways of reducing that, can be an impactful outcome. I hope I answered your question.
Yes, and and this might be my perspective, that closing the gap of social determinant of health may not be as what they're interested in looking at those things.
We're trying. Okay. So you're absolutely right. You're absolutely right. I mean, it could, but so it's looking for more costly outcome. Okay. I see a hand at the back.
Thank you for a very, very interesting talk. A question, and again, perhaps looking at your map, where there is the level of scope of practice, I suspect that at some point there's an interest for nurse practitioners to have full privilege throughout the country. My question relates to those states where there is full practice. Is there any correlation, or have you looked at any correlation between the schools of nursing that provide nursing practitioner programs to develop and create students that have these kinds of skills?
Thank you so much for the question. That specifically we haven't looked, but we have done some papers, and we're giving a talk at Emory on Monday about DMP versus MSN education and impact on patient outcomes. I haven't been trained as an MP. So one of my other colleagues, his name is Grant Marshall. He's professor at the University of Pittsburgh. He's the one who looks a lot on the educational preparation of MPs, but I've never looked how full scope of practice really affects the education preparation. What we looked is how these changes of the MP being the entry to practice, what happens to other existing MPs who are doing an amazing job with the master. So he's the one who's exploring this area. And we have a paper published in Nursing Outlook, and AACN wrote an editorial on it. So, and we're talking about it but we have never really looked at it. One paper we did, was when COVID happened, all governors were giving these executive orders, removing all the restrictions on MPs. We were hoping those executive orders are going to be permanent, but they were not. So we still went back to these different categories of scope of practice. But the goal of our work and the hope is that we might get to that point where, MPs can have one license, a regulation and can practice freely across the country. But I've never looked at that relationship. I'll tell Grant. He loves education type papers. I'm actually going to, that's why I was writing it down. So I'm going to ask him to do it. Yeah. Okay. He loves doing this type of stuff. It's his area. And we try to carve our own paths. Okay. Yes, please. I see 1 and 2.
Thank you for presenting. You mentioned the organizational barriers, and New York is a full practice state, but we still run into insurance billing issues. Has your research looked at that as a barrier?
So thank you. So I should have, one thing I didn't think about that I'm in New York. I should have put all of my New York papers here. So New York, I've done a couple of studies in New York about MP Modernization Act. Insurance, I specifically haven't looked, but I'll tell you what I've looked in New York. When MP Modernization Act passed in 2015, was allowing MPs to have a reduced scope of practice, right? Then now it's a full scope of practice. What we were learning is that state changes the scope of practice, bylaws of organization don't change. So we were actually calling the clinics and asking, like, when we're interviewing MPs, like, so how this change affected you? Like now you don't need a collaboration if you have 3,600 hours of practice. Because in 2015, it was if you were an MP about 2 years, you basically act like a full practice MP without any. And state changed the policy, bylaws were not changed. So we wrote a paper about that as well, saying, well, if you change the state policy, maybe you should also change the bylaws. So, but I haven't looked at the insurance issues because insurance acts very strangely. Some follow Medicare, some follow Medicaid, some do whatever they want if they're commercial insurance. So I've seen that in a various patient. But I think that's one of the reasons we look at all these levels is that you gotta have improvement at all levels to see a bigger impact. If policy changes, organization bylaws are still the old 40-year-old bylaws, then what was that old fight about? So I think increasing awareness about that and it's important and looking at all levels. But yeah, insurance is a area that, and Medicare billing for MPs is a mess. So yeah. I saw a hand over there. Yes. Oh, thank you.
What kind of scope of practice restrictions do NPs have exactly?
Okay, that's a very good question. People define it differently. We use AAMP's definition because there's in the research, some say it's a prescriptive authority or practice authority, like can you prescribe medication or can you diagnose and treat? AAMP defines it by supervision or collaboration. So in a full scope of practice state, you don't need anything. You have your job, you can open your own practice, you can work. In a reduced state, there has to be some paperwork that says I have a collaborating physician, and collaboration can mean anything. I can review your charts every 5 months. I can review your charts every 2 months. I don't have to do anything, so that's a collaboration. And supervision says you should have a physician sign off everything you do. Again, supervision could mean anything. You have a physician who is not even around, but they have to sign that they're supervising. So there is wide variations. That's why in some of our studies, we show that this is really like meaningless. In a practice, what we learn is that MPs and physicians work well together. Longer they work together, relationship gets better, a practice gets better. Very often, we also interviewed physicians, neither physicians nor MPs care what the state scope of practice was because they're like, we work so well together. So some of these restrictions are super arbitrary. It's like, but that's usually AAMP says collaboration, supervision, or none.
Okay, thank you.
Of course. Did I see another hand? Oh, yes, please.
Yeah, I have a question because I'm very interested. I've noticed that Texas, California, which are some of the most populous states,
Florida,
Yeah.
which is a state that has lots of older people with chronic conditions, are red states. How
Okay.
much more is that costing Medicare? And I say that in the sense that we know that the other thing that goes on in many of these states is that, first of all, NPs are usually only compensated at 85% of physician cost. So physicians go around and bill out the physician rate, which in my view is a form of fraud against the federal government. Okay. So how much more is that costing the system in those states to remain red than to convert to a full practice state?
You're absolutely right. That's when I said the Medicare billing is a mess for MPs. Those of you who are not familiar, let me say what it is then. So Medicare says that MP can deliver the service. If they bill Medicare directly, they get 85% of the physician fee for the same service. If physician says, well, I was the one who saw the patient, even though they didn't see the patient, they can ask for 100% from Medicare. So there's that 15% difference. When I first learned about this many years ago, I thought it was a fraud. I was like, what do you mean? Physician has not seen this patient, but tells the government I saw them. That's basically what it means. And let's say, imagine a physician who sees like 300 patients a day. Nobody can see 300 patients a day. They're called like super billers, which is a fraud again. So you're absolutely right that this is costing, but practice is hiring MPs to make money. So the MPs see the patient, they bill under a physician, they make money. It's an outdated, I think, 1960s federal law. There's a lot of arguments about it, a lot of papers have been written about it, but unfortunately, medical lobby is extremely strong. I think that's the reason that's not being changed. There's no other.
I mean, I think that's how much money is it costing
Yeah.
the government to not, to do that, and knowing that
Yeah.
the profit in the grocery
Yeah.
industry is 1 to 2%.
Yeah.
They're
Yeah.
making a 15% profit.
Yep, that's I haven't looked, but I haven't looked the exact numbers to make estimates, but I'm guessing, but absolutely. Yeah, but I think it's another good area to look into. That's why I came. That's because, how does I get a good ideas? You gave me, okay. No, but I agree with you. There has to be a number that says, hey, in these hypothetical scenarios, you can lose $2 billion because of this. Good ideas. Okay, thank you. Yes, please. I saw a hand over there.
Hi, thank you. And just to add to the kind of insult to injury, some of those red states are where we have the highest proportion of Black and brown people, i.e. voiceless people. And there's also states that even with nurse practitioners who have full practice, they cannot, by state law, prescribe buprenorphine for opioid treatment.
So you're stating that, right?
And
Yeah,
yes. I
No.
think there's still 3 states
Yeah.
that refuse to let nurse practitioners.
I wrote an editorial on Forbes a couple of years ago. I also like just writing for fun, but I should do that more. So I wrote something for Washington Post. I wrote one time because I was writing about these things beyond my nursing and interdisciplinary community. So on Washington Post, I wrote something like that. But on Forbes, so a patient came New York City, but the provider could not refill the prescription even though they needed it. It was signed by an MP. It was a few years ago, but it was not a full practice authority. So a patient could not get the prescription filled because it was signed by an MP. So they had to find him a physician in California who agreed to be a co-signer for the prescription so he can get his prescription filled. And it seems so bizarre to me, and that's what the story I told in one of those op-eds, that this is really wrong. So you have a clinician who saw the patient, who thinks they need a prescription. Here's a prescription, patient needs it. They cannot refill it. You need to find someone in California over phone who knows nothing about his patient to refill it. So it's just, and that's why I think I really need more nursing researchers to write about these things and talk about it and produce evidence, because this workforce is growing, they're delivering outstanding care, and these old arbitrary barriers are not serving anybody. And mostly they're not serving the most vulnerable. And we still face these major health disparities in the country. You're absolutely right. Okay, well, thank you so much.